have one last presentation. I think we were saving the best for last. Gabriella Vavala from the US is our last presenter, and she'll be talking about substance abuse, violence, and sexual risk amongst adolescent men who have sex with men who are placed at high risk for HIV infection. So Gabriella, over to you, and thank you so much for being here.
Hello, everyone. Good morning. That was a very big presentation. I feel like I have a lot of pressure now. I'll try to live up to it. So for some background, I'm currently pursuing my master's of public health in the United States. Prior to that, I worked on a study called ATN Cares, and this is a sub-study that we conducted within the overarching study. So I want to take a moment to acknowledge our co-authors and sources of funding. Without them, this research would not have been possible. So in 2021, approximately 1.5 million individuals acquired HIV globally. I want to pose the question, what if we could address the drivers of disease to prevent HIV acquisition? To answer that question, we must shift our perspective to holistically examine the context of disease. The syndemic framework, which was first proposed by Merrill Singer in 1996, is a promising way to examine the drivers of disease. Singer recognized that epidemics tended to arise from social conditions and cluster together. He also noticed that those clustered epidemics were synergistic in nature, meaning that they produced a combined effect greater than their individual effects. One of the many syndemics frameworks is the substance use, violence, and HIV/AIDS frameworks, which is also abbreviated as SAVA. To our knowledge, the prior literature has yet to examine the synergistic relationship between substance use, violence, and HIV/AIDS among young adult and adolescent men who have sex with men, so we sought to do just that. To satisfy that aim, we conducted a sub-study using secondary data from the ATN Cares study. And for background, this study was conducted within the United States. It operated in conjunction with the University of California, Los Angeles and Tulane University. The aim was to engage youth who were at risk for HIV into prevention services and youth who were already living with HIV into treatment services. The study team enrolled youth in Los Angeles, California, and New Orleans, Louisiana from May 2017 to October 2021. We received data from the University of California, Los Angeles ATN Cares team and analyzed the secondary data after we received permission. In our sub-study, we included 415 individuals who self-identified as men who have sex with men, 257 of which were from Los Angeles and 158 were from New Orleans. Since we were examining the likelihood of contracting a sexually transmitted infection, we limited the population of our sub-study to HIV uninfected individuals who were considered at high risk for HIV infection based on an eligibility screener. The ages of participants included in our sub-study ranged from 15 to 24, and the median age was 21. So before I dive into the measures and research findings, I'll explain our conceptual model. The goal of our research was to examine the association between the number of SAVA syndemic conditions and STIs. Here you can see our directed acyclic graph. On the left-hand side, where the light blue box is, we have the number of SAVA conditions, which is our predictor. We categorized participants into having from 0 to 3 SAVA conditions based on the presence or absence of substance use, intimate partner violence, or sexual abuse. We examined the association between the number of self-reported SAVA conditions and a positive or reactive STI result at baseline as the outcome, which is the solid line in the graph leading from the left-hand side to the right-hand side. We also wanted to examine the mediating behavioral pathways between SAVA syndemic conditions. Okay, so hopefully everyone's all awake now, if you were sleeping before. Thank you. So we wanted to examine the mediating behavioral pathways between SAVA syndemic conditions and STIs for potential programmatic purposes. When I refer to mediators during this presentation, I am referring to potential mechanisms or processes that influence the relationship between our predictor and outcome. The mediators are the dashed lines under the yellow box that include condomless sex, number of sex partners, and substance use before sex. We included age and education as our potential confounders. So now I'll explain how we classified our measures. And I want to start off by saying that these are really intense measures, like my fellow presenters have also explained. And the individuals who are administering the survey received a month of training beforehand, so they understood how to handle any potential adverse reactions that may occur in response to these questions. So our predictors, our SAVA conditions, are in the light blue boxes here. We use data collected on substance use and binge drinking. In our analysis, we classified participants as substance users if they reported using an illicit substance within the past 4 months, and/or if they reported binge drinking on a weekly basis. We use the data collected on 2 types of violence: lifetime sexual abuse and intimate partner violence. To measure lifetime sexual abuse, study staff asked participants if over their lifetime they had ever been forced or frightened by someone into doing something sexually that they did not want to do. To measure lifetime intimate partner violence, study staff asked participants if over their lifetime the current or former partner had slapped them, thrown something at them, pushed them, shoved them, hit them with something else that could hurt them, or used a gun, knife, or weapon against them. For the mediating behavioral pathway, we looked at sexual behaviors, which is in the yellow box. More specifically, we used the data collected on the total number of sex partners, condomless sex, and substance use prior to sexual intercourse. For condomless sex, study staff asked participants if they had anal sex without a condom in the past 4 months. For number of sex partners, study staff asked participants if the number of males they had sex with in the past 4 months. And for substance use before sex, study staff asked participants if they drank alcohol or used drugs before the last time they had sexual intercourse. Our outcome was a positive reactive STI test result, which you can see in the green box. We tested participants for HIV, syphilis, gonorrhea, and chlamydia. Participants self-collected pharyngeal, rectal, and urethral samples for chlamydia trachomatis and Neisseria gonorrhea testing, whereas study interviewers collected samples for HIV and syphilis testing. Okay, so now I'm getting to the interesting stuff here. So here you can see that we found a clear relationship between the number of self-reported SAVA conditions and the presence of a reactive or positive STI test result. You can see that as the number of self-reported SAVA conditions increases, so does the proportion of a reactive or positive STI results. More specifically, 11% of those who reported 0 SAVA conditions had a reactive or positive test result. 18% of those who reported 1 SAVA condition had a reactive or positive test result. 22% of those who reported 2 conditions had a reactive or positive test result. And 30% of those who reported 3 conditions had a reactive or positive test result. The number of SAVA conditions was associated with a positive or reactive STI result at baseline in both the adjusted and unadjusted model. Those who reported additional SAVA conditions had 1.39 times the odds of a positive or reactive test result than those who did not report additional conditions in the unadjusted model. Regarding the mediators, we observed an association between the total number of sex partners in the past 4 months and a positive or reactive STI test result. In contrast, we did not observe a significant association between substance use prior to last sexual intercourse and condomless sex and STIs. Based on the prior literature, the lack of a significant association between condomless sex and STIs was an unusual finding. A potential explanation is that we were limited in our ability to differentiate between participants who reported condom use and participants who reported condomless sex, since 75% of participants reported condomless sex. So we have some limitations with our study, and our results should be interpreted in light of the following limitations. First, our study was cross-sectional in our analysis, which limits our ability to conclude causality. Second, we relied on self-reported exposures, so some of the participants may not have felt comfortable self-disclosing information regarding substance use violence, condomless sex, number of sex partners, and substance use before sex. However, that limitation would likely result in underreporting rather than overreporting. Our results should be interpreted with care since unmeasured confounding is likely present in observational studies. So, in conclusion, our study examined the synergistic relationship between substance use, lifetime sexual abuse, and lifetime intimate partner violence among adolescent and young adult men who have sex with men in Los Angeles and New Orleans. We found that each additional reported syndemic condition was significantly associated with a positive or reactive STI result at baseline. Additionally, we found that the number of sex partners acts as a potential mediator between the number of SAVA syndemic conditions and STIs. Moving forward, HIV programs should take a holistic approach to address the various drivers of HIV acquisition. We suggest that those programs consider various and multiple syndemics that put people at risk for HIV infection, including substance use, intimate partner violence, lifetime sexual abuse, and other various traumas. It is possible that those programmatic changes will receive pushback from funders due to limited resources. To combat that pushback, future studies should also investigate the benefit and cost effectiveness of preventing those various social determinants of health as a means of preventing HIV acquisition. In sum, we must acknowledge and address the various drivers of HIV acquisition in order to reach our goal of ending AIDS by 2030. Thank you very much for your attention.